In this lecture, we're going to cover some of the aspects of ultrasound in the air medical environment. Now, there's so many different things we can do with ultrasound, especially in the pre-hospital phase, but we're going to focus today on the FAST exam and evaluating the IVC. Now, especially with ultrasound, this is just the tip of the iceberg. So much of ultrasound comes down to practice. So I wanted to record this lecture so you can go back and look at the information over and over again, but you really got to get out there and practice not just on the sick patients, but also the healthy patients, because so much of it is about understanding how to use the machine, how to move the probe, and what you're actually looking at. Now on our craft, we use the Sonosite iVis. Most ultrasound machines have the same function when it comes down to it. There are lots of fancy bells and whistles, but if you kind of understand some of the basics of the machine, you can really forget about a lot of the other stuff. So this is the basic screen that we see on this machine. It has lots of different functions. I'm going to go through a couple of them, but again, this is when it comes down to practice, 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 and really getting your hands on the machine as much as possible. One important thing to understand in the top right of the screen there, it says cardiac. That's the type of study that we're doing. Now, it doesn't have to be set to the exact study that you're doing. Often there's an abdomen setting or an OB setting or cardiac setting, but what that does is it does actually optimize some of the things like contrast and gain and other settings in the machine. It automatically optimizes it to that study type. So you can do a FAST exam on the cardiac setting. You can do it on the abdomen setting, but you might find that the abdomen setting actually gets you a better picture on the machine itself, but don't worry too much about it. On the left here, we see depth. Now, it's very important to be able to control your depth. Many beginners don't realize that and don't realize that the best resolution for the image is right in the center of the screen. So if you have too much depth on your probe and your image is cramped up top, you're not going to get a good image. Along the same lines, if you don't have enough depth, you might not actually see what you're looking for. So be sure to augment your depth based on what you're looking at. When we're doing something like a subxiphoid view that we'll see on the FAST, we really need the depth around 24 centimeters because we're going to be shooting all the way through the liver up into the heart. But if you're doing something like a IV placement, something very superficial, you want very little depth. So with that depth setting on the machine, you can change it, and then it'll show you at the bottom left what your actual depth is. And based on that number, you can then look to the left of that. All those tick marks actually equal 1 centimeter. So as you change your depth, you'll see the width of those tip marks get larger or smaller. And finally, gain. So gain has a little bit to do with contrast and the power of the signal. So it's one of those things, again, you got to get your hands on to really understand it. But if I were to turn the gain up a lot, what I'd be trying to do is maybe see something on the screen that's not very visible. And I want to turn up the gain to maybe brighten it up and be able to see it. Now, the downside of that is I lose my contrast. Suddenly, everything becomes very bright and hard to see. On the other end, if I turn my gain way lower, everything becomes darker and I lose my contrast. So there is a benefit to changing the gain, but do know that you can kind of go too far with it. And on the machines, there's usually a button to reset the gain. So if you've kind of gone too far in either direction, you can reset it. There are lots of different types of ultrasound probes, and they all serve different functions. These are the three most common that you'll see in the emergency department and also in the pre-hospital phase, depending on what machine you have. On the left is a linear, on the middle is the curvilinear probe, and on the right is the phased array probe. And all these are different in the way that they project and receive the ultrasound signal. On the left, the linear probe, also sometimes called the vascular probe because it's used a lot for IV placement or central line placement, has very shallow depth. It's a very high frequency signal, so it's very high definition, but really only out to 4, maybe 6 centimeters based on the probe that you have. Anything beyond that, you don't get a good signal. In the middle, the curvilinear probe, also sometimes called the abdominal probe, gets much deeper into the tissues. This is why we use it for abdominal exams, often use it for FAST exams, something where we want to really see deeper into the body. It's a lower frequency, so you won't get the definition that you get with the vascular or linear probe. And on the right, we have the phased array probe. Some people also call this the cardiac probe because it's often used for cardiac exams, but it's also often used for FAST exams too, to complete the entire exam. This one's kind of in the middle in terms of frequency and depth as well. It's important to have a basic understanding of how ultrasound works. You don't need to know the great details about it, but in general, there is a sender and a receiver, and that's all housed within the ultrasound probe. Most ultrasound probes used today have an array of crystals that send out an ultrasound signal. That signal hits an object, and based on the wave that's reflected back, based on the power of the wave coming back, the speed the wave comes back, it then will project a picture onto the screen with varying degrees of what's called echogenicity, which is seen as your brightness or darkness, and that will tell you what you're seeing below the surface. So echogenicity is just a fancy word for brightness and darkness when it comes to ultrasound, and so a term that's specific to ultrasound. On the very far left, we have anechoic, and that just means no brightness at all, total black. In general, that is fluid. So when we see dark black on ultrasound, generally it's fluid. It's different from something like an X-ray or a CAT scan where dark black would actually be air. On ultrasound, it's actually fluid because that fluid doesn't reflect any of the signal back. On the very far right, if we have a bright white stripe with black behind it, that indicates likely bone or some other calcified or metal object because all of the signal is being reflected back and nothing's getting through. So you actually have a shadowing behind it. Now in between, we have different levels of echogenicity. So if we have something on that second one from the left or the one in the middle, that's probably more of kind of a soft tissue muscular because it has fluid within tissue, so it's a little bit dark, but also has some densities within tissue that does reflect some of the beam back. So you're kind of getting this in between. So why the hell would we want to use ultrasound on a helicopter? You all have a lot to worry about in the helicopter. A lot of things to take care of for the patient in terms of safety. So why do we want to add one more thing onto the already large list of things you have to do? What's important to realize is that ultrasound can be important, but when we're looking at priorities, it's really not very high on the list. We obviously have our A, B, C, D, E's, and those all go in alphabetical order. So at the very end would be ultrasound if we want to include it. Number 2 priority, critical treatments. Number 3, provider and patient safety. So ultrasound, if it was on this list, would really be number 4, and maybe even number 5 based on the things you have to do. But there are some reasons to practice it and utilize it if you're able to in a safe and efficient manner. And these are the 3 reasons why I think ultrasound is important in the pre-hospital phase. 1, you can make critical diagnoses. This may be a pneumothorax that actually has tension physiology. This may be a cardiac effusion that has a tamponade physiology. Those are 2 things that come to mind that actually could indicate the need for a rapid treatment that could potentially be life-saving. Treatment decisions are also important. So how do we want to treat this patient? So we have someone who's hypotensive, but it's undifferentiated hypotension. Well, this can kind of help tease it out. Is this cardiogenic? Is this hypovolemic? Is this obstructive? And knowing how to use your ultrasound, within 10 to 30 seconds, you can actually uncover some aspects of the patient's physiology that can push you in a different direction of how to treat this patient. And finally, treatment response. So to say this is a hypovolemic patient, we've determined that based on the size of the IVC and the collapse during respiration. Well, now we've given blood or we've given fluids, and now we can actually see how has this patient responded to the treatment that we've administered. So as I mentioned at the beginning, we're going to focus on 2 different studies here, the FAST exam and the IVC. So starting with the FAST exam, what FAST stands for is Focused Assessment with Sonography for Trauma. Now, the acronym FAST also makes sense because this is a rapid study. We should be able to perform the study in probably 30 to 45, maximum 60 seconds to help try to uncover some immediate life threats or make some diagnoses in the patient in front of us. So there are 4 basic views in the FAST exam. And what we're doing with each of these views is looking for free fluid where it shouldn't be. That's usually in the abdomen or the pericardium. Now, in trauma patients, free fluid equals blood until otherwise specified. Now, obviously, a patient can have ascites, they could have a known effusion in their heart, but in the pre-hospital phase, you're not going to know these things. So we have to assume that free fluid in a trauma patient is blood until otherwise proven. Our 4 primary windows for this exam are the right upper quadrant, the cardiac, left upper quadrant, and the pelvis. Now we'll add one more thing on the FAST exam and have what's called the EFAST, or the Extended FAST exam. Now the EFAST tacks on lung views, and what that's doing is looking for pneumothorax. So obviously something we worry about in trauma, so this just adds a couple more views to evaluate whether we think this patient may have a pneumothorax. So I'm going to go through the FAST exam, and I'm going to use lots of images and videos to show you where to place the probe, how to hold the probe, and what normal and abnormal looks like. And almost all of these came from POCUS101.com. Fantastic free site that has great education. So if you want more information, I would advise that you go check them out. So first we'll start with the right upper quadrant view. To obtain the right upper quadrant view, there's a couple different ways to do it. I usually start kind of mid-axillary line on the right side. You can also start at the xiphoid and run your way down the margin of the ribs, but you're just trying to get to where you would think the kidney might be. Now the idea of the right upper quadrant view is to look in what's called Morison's pouch, and that's going to be the potential space between the liver and the kidney. In this view, you can also see the lung, and you'll be able to see possible traumatic effusions or some other findings, but we're really focusing on the area between the kidney and the liver. In this view, we can see the arrow pointing to Morison's pouch. So in the liver here on the left, you can see what that looks like. And there's a very faint, bright white border between the liver and the kidney. Now, I just always think of a kidney being what that looks like, and that's pretty much what the kidney looks like. So if you can find those two structures and the bright white line between them, then you can find the right place that you're looking to find free fluid. And again, looking for dark black.
A phased array transducer with an abdomen exam type is used to perform the right upper quadrant view of the FAST exam. The orientation marker is directed toward the patient's head. The transducer is placed in a long axis orientation along the right mid-axillary line between the 7th to 9th intercostal space. Rotation and oblique positioning of the transducer will help eliminate rib shadows. To evaluate the entire area of the hepatorenal recess for free fluid, sweep the transducer from an anterior to posterior position. If present, fluid will appear as a dark or anechoic stripe between the kidney and the liver. If it is difficult to visualize the hepatorenal recess, a deep inspiration will move the diaphragm and other structures in this area down and below the ribs for easier access. Sliding the transducer upward will visualize the diaphragm and pleural interface. Sliding the transducer downward will visualize the inferior pole of the right kidney.
So in this side-by-side view, we're able to see normal right upper quadrant view on the left and abnormal right upper quadrant on the right. On the left, we see an interface between the liver and the kidney, and we see kind of more hyperechoic, so brighter white tissue there. So that's indicative of some connective tissue, momentum, some other things, but not the fluid that we're looking for. Within the liver, we do see some dark black circles. Now those are going to be vessels, which we'd expect to see within the liver. On the right, we see an abnormal finding. We see a dark black pouch at the very tip of the liver, and then extending between the liver and the kidney. And this is indicative of free fluid. And again, in the setting of trauma, we're going to assume that this free fluid is possibly blood. Now we'll move on to the left upper quadrant. So left upper quadrant is somewhat similar to the right upper quadrant, but obviously on the left side. It's a much more difficult view though. In this view, I always advocate for getting your probe all the way down to the bed. The spleen renal interface that we're looking at is often very posterior. So really I start with my hand down the bed, and it's often higher up more towards the head than the right upper quadrant area is. So sometimes you're actually having to go up between the ribs to find the splenorenal interface. So similar to the right side, and this side we're looking at the kidney and the interface between the kidney and the spleen. And you can also pick up lung and diaphragm as well. So the left upper looks a little bit similar to the right upper quadrant, except backwards. And the spleen is obviously going to be smaller than the liver. Like I said, sometimes you actually have to get up between the ribs, or you can see it kind of poking out from under the ribs. So I might have the patient take a deep breath in if they can, and actually slides these structures out from under the ribs and gives you a good shot. On the left of this image, you can also see bright white diaphragm sitting right above the spleen, and above that on the left would actually be lung tissue. So again, just like the right upper quadrant, we're looking for dark black within the interface between the spleen and the kidney. Here we can see dark black in the spleen, that's blood vessels. In the kidney, we also see it, and that's probably just some small level of hydronephrosis within the kidney.
A phased array transducer with an abdomen exam type is used to perform the left upper quadrant view of the FAST exam. The orientation marker is directed toward the patient's head. The transducer is placed in a long axis orientation along the left posterior axillary line between the 5th to 7th intercostal spaces. The sonographer's hand will touch the gurney with the proper transducer position. Rotation and oblique positioning of the transducer will help eliminate rib shadows. To evaluate the entire area of the splenorenal recess for free fluid, sweep the transducer from an anterior to posterior position. Carefully examine the splenorenal recess and subphrenic space. Fluid will appear dark or anechoic. If it is difficult to visualize the splenorenal recess, a deep inspiration will move the diaphragm and other structures in this area down and below the ribs for easier access. Sliding the transducer in an upward direction will visualize the diaphragm and pleural interface.
Now again, a side-by-side shot of normal on the left, abnormal on the right. On the left, we see some middle echogenicity structure in the middle of our screen. On the left is a bright white line, that's the diaphragm above the spleen. And on the right, we see that interface between the darker kidney and the splenic tissue. So we're looking for fluid in between those two. On the right side, we see an obvious positive finding. So what we're seeing is fluid around the spleen, actually more on the superior part of the spleen. So not even between the spleen and the kidney, but more between the spleen and the diaphragm. And that would be concerning for a splenic rupture. So our third view is our cardiac view. Traditionally, a lot of people are taught to start on the left side and go from there, but a lot of people also advocate for starting with the cardiac view, especially in penetrating torso trauma, because you want to go ahead and rule out something like a tamponade. There's multiple ways to obtain a view of the heart. The one we're going to teach here is what's called the subxiphoid view. So you're actually going under the xiphoid process. Now to obtain this, you have to actually be farther down than you think. You're not going right on top of the heart. You're actually moving the probe almost between the xiphoid and the umbilicus, a little bit to the patient's right, because you're actually shooting through the liver. So before I talked about needing really deep measurements on this, usually around 20 to 24 centimeters, is because you really have to penetrate a lot of tissue. Now, liver also helps because it has some fluid-filled components. It actually helps as what's called an acoustic window. It actually intensifies your ultrasound signal. But really, you want to be holding the probe like the person is here in the picture. You want your hand on top of the probe, and that actually allows you to push in and kind of sink the probe up under the rib cage and point up towards the heart. Now, one thing that always kind of confuses people when we're looking at the heart is what structures are we actually looking at? So remembering that the RV is actually the closest structure to the surface in most people. So when we're looking at the subxiphoid view, the very front structure we're going to see is the RV and the RA, with the left ventricle actually behind those structures.
A phased array transducer with an abdomen exam type is used to perform the subxiphoid or subcostal view of the heart in the FAST exam. Place the transducer in the subxiphoid position with the orientation marker to the patient's right side at a 9 o'clock position. This view uses the liver as an acoustic window to visualize the 4 chambers of the heart. Aim the transducer slightly toward the left shoulder at a 15-degree angle to the chest wall. In some cases, the transducer is almost flat to the abdominal wall, so the ultrasound beam is directed toward the left chest cavity. A considerable amount of ultrasound gel and downward pressure may be needed to maintain contact of the transducer face with the abdominal wall. Increase scanning depth to visualize all chambers of the heart. The first structure seen closest to the transducer is the liver. The right side of the heart will appear closer to the transducer than the left side of the heart on the ultrasound image. The myocardium will appear gray, and the blood-filled chambers will appear hypoechoic. The bright white pericardium is seen surrounding the heart adjacent to the gray myocardium. Evaluate the function of all chambers. Compare the size of the right and left ventricular cavities. Note any wall motion abnormality and the presence or absence of pericardial effusion.
Now, there is a lot to learn about cardiac ultrasound, but again, we're just focusing on immediate life threats at this point. So one thing we can look at is what's called a sad heart or a happy heart. So when we're looking specifically at the LV, let's look on the left image here. I would actually kind of call that somewhat of a sad heart. The LV is not really contracting together very well, but I do see cardiac activity. So if I'm doing a cardiac arrest, I might at least be able to know this person has cardiac activity. It's just not great. But I don't see any fluid surrounding the heart. We can see the top arrow pointing to the liver, and then the bottom arrow pointing to the bright white pericardium. On the right side is a subxiphoid view, and between that pericardium and the heart is a black stripe. And you can see that stripe changes sizes as the heart actually contracts and relaxes, and that is concerning for cardiac effusion. So dark black stripe between those two layers is fluid around the heart. Now it gets a little more advanced. We're trying to figure out tamponade on ultrasound. But what you do is you take this information, put it together with other clinical signs like hypotension, JVD, all that good stuff, to determine if you're concerned this patient might actually have tamponade. Now the final view on the FAST exam is the pelvic view. And this is going to look for fluid within the bowel or surrounding the bowel and surrounding the bladder. This view may be one of the harder ones to get in the craft, depending on what craft you're in and what your position is, but you really want to get right above the pubic symphysis. The way I do this view is I actually palpate the pubic symphysis with my hand, and I go right above it, because you're actually trying to aim down and behind the pubic symphysis. Now you can go in either a transverse or long view with this study, but what we're looking for is the actual bladder. Again, you can see the pubic bone, and the bladder sits right behind that, so you actually have to press in and kind of try to shoot that beam behind the pubic bone. This can be a difficult study to get. If you don't see anything, also ask the patient if they urinated recently, because if they don't have any urine, you're not going to see anything.
A phased array transducer with an abdomen exam type is used to perform the pelvis view of the FAST exam. Place the transducer in a transverse position with the orientation marker to the right at the level of the symphysis pubis. The pelvis is evaluated in 2 planes. It is easier to perform this exam when the bladder is filled. The bladder is used as an acoustic window to view the cul-de-sac or retrovesicular space for free fluid. To visualize the bladder, angle the transducer inferiorly into the pelvis. If it is difficult to visualize the bladder, slide to the left or right of the symphysis pubis to bring the bladder into view. To evaluate the pelvis for free fluid, sweep the transducer from an inferior to superior position. Fluid will appear hypoechoic or anechoic and accumulate posterior to the bladder, posterior to the uterus, and between loops of bowel. To obtain a long axis view, rotate the transducer 90 degrees with the orientation marker pointed toward the patient's head. Sweep the transducer across the pelvis from left to right to evaluate the pelvis for free fluid.
Now here we see a typical normal view in a female. So the very first structure we see, a nice big fluid-filled bladder. So we're looking for that big black balloon sitting behind the pubic symphysis. Under that is uterus. With males, you'll often see the prostate sitting behind there, and then we can see some rectal structures behind that as well. So here we see an abnormal finding. We have the large fluid-filled bladder, but then to the left or superior of that, we're also seeing fluid-filled structures between that and the bowel. So the bowel is kind of obstructed, hard to see because it's filled with gas and air obstructs the ultrasound view. But between those structures, we see some black collections of fluid. So again, in the setting of trauma, that would be concerning for intraperitoneal fluid. So as I mentioned before, we're discussing the EFAST, and the way we get an EFAST is we add the lung views on to evaluate for pneumothorax. This is best done with the linear probe, but you can also do it with a phased array probe, really any probe, but just the superficial linear probe is best for this. And you're trying to get between the ribs. So you're going to go on the patient's chest, you're going to have the probe indicator up to the patient's head, and it's going to shoot a beam between the lungs and take a slice of the lung parenchyma. And it's going to show some subtle findings that will tell us if this patient's lung potentially has a pneumothorax. Here's a drawing of what we're seeing. So the very first thing at top, the yellow, is obviously the soft tissues. On either side of our image should be ribs. So they're going to be bright white with shadowing behind it, so you won't see anything behind it. So what you're trying to do is get that probe in the right position so that you have a rib on the left and the rib on the right. In between those, we're going to see the lung tissue. And we're also going to see a little bright white line that's the pleura as well. We'll be able to see that pleura moving.
A linear array transducer is used to evaluate lung sliding as an extension of the FAST exam. The orientation marker is positioned in the direction of the patient's head. The transducer is placed in a long axis orientation over the anterior chest wall at the third or fourth intercostal space in the anterior axillary to mid-clavicular line. The ribs are identified in the near field of the image as a bright interface with a posterior shadow. The pleural line is identified as a bright hyperechoic line between the rib shadows. The to and fro sliding movement of the visceral pleural against the parietal pleural with breathing generates the lung sliding sign.
Now here's a good video of pleural movement. So as the patient breathes, we see what we call ants marching across the line there. So we see that pleura sliding back and forth. That it shows you that this person has intact pleura and likely, at least in this area, doesn't have a pneumothorax. Now, if you have a high concern, you may need to look at other rib spaces as well because the patient can just have a smaller pneumothorax somewhere else. But this would be a sign for positive lung slide, which would be indicative of not having a pneumothorax in that area. And on both sides of that bright white line, we can see the ribs. So we see there's subtle bright white densities that have shadowing behind them that we can't see anything, and those are the ribs. Now this is an abnormal finding. We do kind of still see a little bit of movement, but really not we'd expect the sliding back and forth of the patient's pleura. So this would be concerning for pneumothorax. Now there are other more advanced studies we can do with things called M-mode, but that's a little more advanced, takes a ton of practice and to figure out exactly what you're seeing. So really we want to know, is there lung slide or is there not? So let's go through a few examples of what we might see in a patient while we're doing the FAST. So as we look at these, I want you to try thinking in your head, okay, what view is that? Is it normal or abnormal? And what are we seeing? So this view would be a right upper quadrant view. This would be the tip of the liver floating in a black anechoic volume that we'd be concerned for free fluid, extending into Morrison's pouch between the liver and the kidney. So this view would be a left upper quadrant view. It's very obvious because it's labeled there. We see the spleen. We see hypoechoic black surrounding the spleen. We also see some other just kind of muckiness in that area. And that can just be different densities of blood. It could be splenic tissue, a parenchyma. If the blood's been sitting there a little bit, it will coagulate and actually cause more hyperechoic densities. And below that spleen, we see the kidney. So it looks like hemorrhage within probably the capsule of the spleen. Here's a subxiphoid view. So we're looking at the heart. Remember that first structure we're seeing is the RV. And right on the outside of the RV, between it and the pericardium, is a collection of black anechoic density that's concerning for a pericardial effusion. Here, this is the pelvic view. So the probe indicator is pointed up to the patient's head. So on the right side, we actually see right there, we see the bladder, kind of a balloon structure right there. And then in between the bladder and some bowel, we see a collection of likely fluid. And here on a lung ultrasound, we see absent lung sliding. So no ants-marching. Concerning in the right setting would be concerning for pneumothorax. This is something a little bit different. We see lung slide, but then it stops. So on the right side is sliding, and as they breathe in and out, there's an area where it's not sliding. So that would be concerning what's called a lung point. So that's actually more of a focalized pneumothorax. That's more of a small pneumothorax. So you're seeing the very tip of that lung slide in and out. Here we're seeing what's actually air artifact. So I discussed earlier what different densities do with ultrasound signal. Air just disperses it. So ultrasound signal just kind of flies everywhere once it hits air. So you get a lot of artifact. So if you happen to be doing an abdominal exam and you see this kind of artifact and it's obscuring everything you see, you could be concerned for intraperitoneal free air. Now, it could be air from the bowel, sometimes hard to see. You also need to make sure you have a lot of gel on your ultrasound probe and that you don't have air between the probe and the skin. But again, the right setting, this would be concerned for free air in the belly. So we've covered the FAST exam. Now we're going to go over the IVC. That's obviously for the inferior vena cava. And this structure comes from the RA, or I guess connects to the RA, and brings blood from different areas of the body back to the heart. So what we can use this study for is an indicator of the total volume status of the patient. It's not a perfect study. To really get into it takes a lot of advanced knowledge and some calculations. It's also differences based on whether they're intubated or not intubated, because our total chest physiology changes based on what's going on there. But in general, you can get kind of a global picture of what might be going on with the patient's fluid status to, one, determine what you think is going on, and two, possibly figure out how the patient is responding to treatments. So as I mentioned, this can give an idea of the patient's overall fluid status. So the IVC exam is going to be done kind of between the xiphoid and the right upper quadrant that we did for the FAST. So if you have your right upper quadrant, you actually kind of slide medially and hopefully capture your IVC. Now remember that it comes out of your right atrium, or connects to your right atrium. So if you can't find it, you can actually kind of push your probe up under the ribs like you do with the subxiphoid and find your right atrium contracting and actually see it connect to that. If you slide too medial, you'll see a similar structure that's pulsatile. That's going to be your aorta. So you want to go just lateral to that. Ideally having your probe indicator up to the patient's head to get a longitudinal view.
A phased array transducer with a cardiac exam type is used to perform an inferior vena cava ultrasound exam. The inferior vena cava is evaluated at the level of the liver and diaphragm. The transducer is placed to the right of the epigastric midline with the orientation marker to the patient's feet. As an alternative approach, this exam may be performed using an abdomen exam type with the orientation marker to the patient's head. The liver, diaphragm, right atrium, and inferior vena cava are identified in this view. Sweep from side to side to differentiate the inferior vena cava from the aorta. The aorta is thicker-walled and pulsatile. The superior mesenteric and celiac branches of the aorta are identified at this level. The inferior vena cava is thin-walled and changes caliber with respiration. The diameter of the inferior vena cava decreases with inspiration and increases with expiration.
So here we can see different ways to hold the probe, but what we're seeing, and you can see where they've placed the probe kind of just to the right of the subxiphoid, right under the rib cage. And on the bottom, it shows the structures we're seeing. On the very right, if this was a live view, you'd see the RA contracting. Extending down from that is the IVC with some other vessel running off to the liver right above it. So here's a live view of the study. At the bottom, the anechoic black large structure is actually the IVC. If you were to scan up a little more to the left, you'd see the RA contracting. And running off the top of the IVC, there are some hepatic vessels. Now, the whole point of the IVC study is to figure out, is the IVC large or is it small? As I mentioned before, getting into the numbers and details becomes very advanced and depends a lot on different patient factors, whether they're sitting up or laying down, whether they're intubated or not. So I wouldn't worry about that too much. What I do at the bedside is, does this thing look big or does it look flat? If it looks big, is it collapsing with respiration? Because as people breathe, we expect it to have some variation. If there's a very big, fat IVC that's not collapsing at all when the patient breathes, I would call that a plethoric or a very large IVC. And that can be a sign of hypervolemia. So if you have a patient who is short of breath, has pulmonary edema, they're on BiPAP, they're needing nitro for their high blood pressure, and you see this huge IVC, that patient's probably hypervolemic. It would indicate something like a CHF exacerbation, because they obviously have a lot of fluid backing up into their IVC. Now this one's a little bit different. We're seeing the IVC there in the middle. On the left, we actually see the right atrium contracting. And every time this patient breathes, the IVC completely goes flat. So again, not focusing so much on how big it was before, or how big it is after, or the ratio or anything, but the fact of the matter is the IVC is not that big, and every time they breathe, it completely collapses down. I would worry that this patient might be hypovolemic or fluid down. So again, the right setting, if I now have a hypotensive patient, and especially in the setting of trauma, I'd worry about volume or blood loss. Or if they were septic and they were hypotensive, I'd worry that maybe this patient still needs more volume. Or maybe go ahead and keep giving a little bit of volume till we get that IVC a little better, and then we can consider pressors, or maybe starting fluid and pressors at the same time. But you can see how this takes a completely undifferentiated patient and at least gives you an extra piece of the puzzle to work with. So that's what we're going to cover for the FAST exam and IVC. I know it's a quick review, but I want to just get the basics down so that we can practice from here on out. The three things I want you to really think about is, first off, you got to practice. I've always said this, that ultrasound is 90% practice, 10% didactics and learning. It's really learning how to use the probe. So you don't even have to look at the probe. You know what your hand's doing. You know based on your image what you need to do with the probe. That's where it all comes from. With that in mind, ultrasound's all about small movements. So anytime you're rotating to try to get a better picture, or sliding the probe to get a better picture, it's very fine movements, millimeters at a time, because you want to try to find a structure within your image and then augment to optimize that structure. So if you're moving centimeters to inches at a time, you're probably moving too fast and you're going to miss what you're looking for. And finally, trust yourself. If you practiced, and you understand the foundations of it, you're going to do fine. There are very few things, you're really not going to do anything with ultrasound that's going to hurt someone. Just don't wrap the cord around the patient's neck. And it's not really going to lead you down to any procedures that could potentially hurt the patient. If you end up doing a needle thoracostomy based on your ultrasound, you probably already had a suspicion for it in the first place. Same goes with a cardiac effusion or tamponade. You probably already had a suspicion. The ultrasound is just another piece of the puzzle. So trust what you're seeing. Let it help and guide your treatment. And just keep practicing. And I promise you, it will help your treatment of the patient in the field.